Okay, so let's go on to treatments now, because this is relatively quite. There's lots of treatments out there, right? But the mainstay treatment for chronic UTI, is antibiotics, but just a long course, right? And obviously we can't say how long. But say if someone comes to see, someone comes to see you, maybe they had, I don't know, a year's worth of 3 days stuff, antibiotics, they've still got symptoms. What would be the kind of, and they say they've got E. coli on their, I don't know, on their broth culture. So what would be the mainstay treatment in someone like that?
Yeah, so I think first, one of the first things to try and work out is it a kind of a recurring or a persistent UTI? Because there are these, and again, I'm not trying to. I mean, I've given an idea, give you a bit of an indication of what the sort of difference is between the way them, but sometimes it's not entirely obvious. But the way you deal with, I mean, I think the way you deal with recurring, genuine recurring UTI, there's a number of different treatments that can be used. So, in postmenopausal women, I think one of the first things to try is things like vaginal estrogen.
Which works great, by the way, doesn't it? I've tried that
Yes,
before. It works really well.
Very well. If it's recurring UTI due to a particular trigger, so so those we can find it as a result of, it could be after sexual intercourse. You can have sort of treatment sort of dedicated to that time. So you can have what's called post-coital prophylaxis, where you have to take a single dose of antibiotic around the time that you're likely to be at risk. So there are different ways. Then there are sort of non-antibiotic based treatments. So good example, there's things like methenamine hippurate is something there was recently a great clinical trial led by my friend and colleague Chris Harding, showed that that's as good as antibiotic prophylaxis. It wasn't inferior. So I think that's a great system. So. And there are a few other sort of non-antibiotic based treatments that can be used if this is recurring UTI.
So
ultimately you might look at antibiotic prophylaxis as well. So long term antibiotic prophylaxis. However, if it's persistent UTI, then the first thing you're trying to do is get rid of the persistence. And if you know that if there's something has grown there, then that's going to be your target, and you want to give an extended course of antibiotics to try and see if that can be shifted, much in the way that you would for any other kind of persistent infection.
I see. And so let's go through just some of the non-antibiotics. We mentioned methenamine and topical estrogens, but I was and some that I've come across. So one of the ones that a lot of people use, which I think is quite a good place to start, is mannose.
Yeah.
What are your thoughts on that?
Yeah, I think mannose is a great example of a non-antibiotic, and it's certainly been effective. And there's now a number of clinical studies that have shown that. What I love about mannose, actually, in particular, is the fact that I think this is one that came from patients. This was not something that clinicians were sort of necessarily saying, "Hey, we've got this thing, we'd like to." No, because that's where we often think of treatments, don't we? The clinicians come with a treatment that ask to take it. Patients were using this themselves and were finding good responses to that. And that actually triggered then clinicians to start looking into this. And lo and behold, I think there's definitely a value in using that. I think one of the only annoying things about mannose is that because it's come through that route, it's still not a prescription drug. And what that means is people have to buy it as typically buy it as a supplement, from a from pharmacist or a health shop, and actually can be quite expensive. It's certainly more than the cost of an NHS prescription, and so I think that's problematic. And I would really like to see that become available through prescription, so that everyone can have who needs it can have access to it.
And what about everyone's favourite cranberry products?
Yeah, so that's an interesting one. So I think there probably is some benefit there, but maybe not as much as perhaps people have thought. I think where there is most likely to be the benefit is probably on the cranberry tablets, where they've really tried to concentrate the relevant component. I think with cranberry juice, really you have to have a hell of a lot to make it worthwhile. And the danger of that is that you're also consuming quite a lot of sugar, which generally speaking isn't good for anybody. It's certainly not good if you're a diabetic. But even from an infection point of view, having lots of sugar and yes, probably not an ideal situation. But yeah, in terms of in terms of cranberry itself, the agent, there probably is some value, but again, it probably has to come through a tablet, which again brings us back to the same sort of problem as D-mannose. That is, you're probably going to have to get it as a supplement. Costs of that can vary, and the other problem, which again also applies to D-mannose, is the formulations can vary. Depending on where you get it, with different concentration, how effective is one compared to the other, and that's where I think where pharmacological medicine, at least we know what we're getting. We know the standardized. This is the dose. This is the amount. This is the amount a person should take. I think this is where we struggle a little bit with the supplements. I still think that they're a value, but I think you need to just recognize that we don't always know what the amount from different places, and I think there is this cost issue. And often you're having to use this for quite extensive periods of time, so that cost can really mount up for patients.
Yeah, that'd be. Patients have asked me. Sometimes they bring things to me, and I'm like, well, yeah, it looks quite okay, but you're never really sure because supplements are not regulated, right? So it'd be quite good if there was a way of there's someone that had like maybe D-mannose and cranberry concentrated in one, and they had on the back dosage with the testing certificate show. That'd be the perfect,
Yeah. And who knows? Maybe one of the the generic companies, etc., might pick this up if there's sufficient evidence. But it is difficult because once these things are out there in all these different ways, it's hard to roll it back and create one standardized version that we're all using. So in a way, the genie's out of the bottle there. Yeah, I think this is going to continue to be tricky.
Yeah, I mean, so non-antibiotics, we've got cranberry, D-mannose, estrogen, methanamine. Another one actually that's becoming quite a lot of curiosity about is vaccines. And I must be honest, I don't know that much about them, but I know I've looked at them quite a lot and read a lot about them. But a lot of people are interested in
that's right.
Vaccines for chronic UTI.
So I mean, vaccines have been around for a while actually. So some of them have been out longer than others, and they've taken different forms. The tablet, a kind of vaginal pessary type agent. But the one in recent times it's become very popular is once put in sublingually. There's a vaccine that's used that, and that's that's a relatively recent thing, and that seems to be genuinely has had really good results with recurrent UTI, and the data that's been presented at a number of conferences. So there's a couple of UK urologists, Yang and Foley, who have really done quite a lot of the work on that, and regularly present the data at the urological conferences. As the data's evolving and getting more. So they did the original study, and then they presented it. Almost every couple of years a further update on where they've got, and definitely the results on that look good. I think particularly that one, it works through a different mechanism of action. They talk about something called mucosal immunity. So instead of like a tablet or an injection or whatever, this is because it's going through the lining of the mouth called the mucosa. It's triggering immunity in a sort of in a different way, and that seems to be particularly effective in enhancing the immunity within the bladder. I think there are some ongoing question marks on this. One of them is that, okay, you take this and clearly it's effective for a period of time, but when do you, like with any vaccine, when do you need another amount? When do you need the next dose? Or is how long is it going to last for? Is it a year, 2 years? For how long? So I think that still is there. Also, like many vaccines, there's a possibility that maybe it works better at the younger end of the age group. Most vaccines do, because if you're relying on anything to do with the immune system, you're generally relying on a response, and we know that from other types of vaccine that certain things can work better within younger populations than older. Again, so there are all of these sort of questions that do need answer. But I think that's a really promising area, and I think, again, great non-antibiotic treatment. And I think I intrinsically always like anything that helps your own immune system, because ultimately that's what you want, isn't it? You want something that helps you fight infection better, rather than something you have to keep taking that's doing the job. And in fact, vaginal estrogen probably works in the same way. It enhances your own immune response.
Okay, and who would be the ideal candidate for a vaccine? What kind of patient?
So I mean that's good. I mean, again, I think the ideal candidate is the most of the data is for women, although there is some data for men as well. And they said to me for what we call true recurrent UTI. Again, it comes back to this issue with, when we talk about recurrent and chronic UTI is difficult to define anyway, and therefore difficult to do a study to show that. So the best evidence is within, probably recurring UTI where you've got episodic in. Whether it's helpful in chronic UTI or not, again, we don't have huge amounts of evidence. Anecdotally, definitely a number of patients have found benefit. But yeah, it does. I think it's something that I guess we'll learn more about over time.
Okay, I think that covers most of the non-antibiotic stuff. But even with the antibiotics, we talked about sort of prophylactic and the extended courses. But another useful thing I think is going back to what we said about a patient's symptoms being very sensitive for a UTI is self-start antibiotics.
Absolutely.
Because I think it's E. coli doubles, like what is it, like 20 minutes, every 20 minutes is doubling your number.
Yeah.
So I think by the time now, by the time you call up your GP, get an appointment, the 3 days are not going to, are not going to work. So.
Exactly. Yeah. So I think self-initiated, and this is all in the, just to be clear, this is in the NICE guidelines, post-coital self-initiated antibiotics. These are all recognized and agreed methods of treating. And yeah, the idea is that if you nip this in the bud at an early stage, you're not going to get, you don't get a chance for the infection to develop. Now, just to be clear, because earlier in the conversation we were talking about the fact that short courses of antibiotics, that's not, maybe there's some issues with that. This is not the same as saying giving a short course. No, this is literally at times 1, maybe 2 doses at the time when someone is just getting the symptoms. It's really early. You're trying to essentially never let the infection even establish itself. Once an infection is established, then you of course need a proper course of antibiotics. So this is prophylaxis. This is not the same as treatment. And prophylaxis we do in a number of other situations as well. Classic example is surgery. At certain time of surgery, we give antibiotic prophylaxis. We give a single shot of antibiotic. And the idea is you give that bit of antibiotic at the time when it's very early, and hopefully you've just got rid of everything before it even has a chance to establish. But really glad you brought up the point about the replication, the duplication time. Because every 20 minutes it doubles, and what that means is that when someone, the time between when someone gets symptoms and then gets to their GP or the healthcare provider and then gets, that can be days. Imagine how much that small bit of infection has grown. So that's why self-initiated antibiotics can be very effective, because it nips things in the bud. The other thing that's really nice about self-initiated antibiotics, I think, is from a patient perspective, it gives you back control. I think there's nothing worse than knowing you've got a certain problem, knowing that this is what I need to get on that problem, but I can't get it till 2 days' time or whatever it is. I think that's really disempowering. And I think, given we know how reliable symptoms can be, I think self-initiated antibiotics is very useful.
Yeah, no, I really like using them, especially in patients who know they're getting UTI, so they might get like a slight rumble in their stomach or a slight stinging, and it's really useful for them, I found. So yeah, another kind of, I guess, is more of your field. Obviously, we've done the non-antibiotic and antibiotic treatment is around sort of bladder therapy directly, where you can get things like gentamicin infusion and things like that. Yeah, so what's your experience with those kind of treatments and how effective are they?
Yeah, so I think gentamicin instillation, so where you create a solution of gentamicin, typically in about 50 mils of saline or water, and then inject it into the bladder. You might use some other things like local anesthesia and things like that to further reduce symptoms. I think that can be very effective. The great thing about gentamicin is it's a great antibiotic against a large number of different UTI-causing bacteria. And plus, you're putting it directly into where the problem is occurring. And we know gentamicin has good penetration within the bladder as well, because of the way that its molecule is and the charge and so on, and has very little in the way of side effects because it's not getting into the rest of your body. So that's all of those side things. It's great, and I think it can be very, it can be very useful. And there is evolving data on that. I know they did a study in Bristol where they got patients to use it, even do it themselves at home. These were patients who had a catheter actually in and so on. But there is definitely 1 or 2 other studies, and it's certainly being used increasingly in urologic departments. It is still, if we're honest, pretty awkward, because it's not easy to get things into the bladder. You're going to have to put a catheter in and inject it. It's not easy to prepare because gentamicin comes, it comes in a vial. It needs to be mixed into, so it doesn't come in a ready-made form to do this yet. And I think thirdly, it must be considered it is an off-label treatment. And what I mean by that is that that there hasn't, no pharmacological company has gone and done a study on this and produced doses, etc. Yes, there have been studies done by clinicians to look at this and so on, and it seems to be safe and effective. But you can't open up a vial of gentamicin and find in the instructions, okay, if you want to use it as an instillation, this is what you need to do. That doesn't, it's off label. And one of the reasons it will probably remain off label, probably for the foreseeable future, if not forever, is that it's a very old drug. So there's no pharmaceutical company that is whose interest it's going to be to go and say, oh, right, let's go and develop this and do this, because it's an old drug. It doesn't belong to anybody. It's a generic drug. And so that's both the good thing because it's very cheap, but the downside is it's hard to make it in an ideal world. This would come in some sort of kit where it's all ready and you could just easily inject it, and then maybe even patients could do it themselves. You definitely see an opportunity there. But the problem is that, like many things in healthcare, there has to be a way for people to make it commercially viable. And I don't think, with a drug that's that old, it's just not possible.
Yeah, I mean, so that's one. And also I've had some patients report good results with sort of GAG kind of therapy.
Yeah,
kind of where...
get GAG replacement therapies. Yeah, so it's a GAG, which stands for glycosaminoglycans. That's this layer, this sort of mucus-like layer that's within the bladder that normally exists. And so these agents were originally primarily developed to treat interstitial cystitis, because what we know from interstitial cystitis, going back to what I said before, there are types of which clearly is interstitial cystitis, certain changes. So we know from those people where their bladder's been analysed that there's a deficiency in the GAG layer, this glycosaminoglycans layer. And the idea of these instillations is to try and replace some of that. So you put it on and it hopefully adheres to the bladder wall, and it helps replace some of that inner layer coating, as it were. People have tried this out then in urinary tract infection, in recurrent urinary tract infection as well. And within that population, we also know that there is that UTI causes an injury to the bladder and can also affect the glycosaminoglycans layer, the GAG layer. And therefore, using these treatments has shown some level of effectiveness. I mean, my one doubt about this, and I genuinely don't know what the answer is this really just a symptomatic treatment? Is it actually doing anything for the infection itself? So, like with gentamicin, that's an antibiotic. I know that's killing the bacteria, or has the ability to kill the bacteria. With these agents, I think they do have some antimicrobial activity, but is that their primary mechanism of action, or is it just kind of soothing the symptoms? That doesn't mean to say they don't have a value. If you've got recurrent UTI and all of these symptoms, just even soothing the symptoms has value. But is it? I would like to understand better, how are they working? Are they actually doing anything for the underlying mechanism, or is it just is it almost a form of a pain relief, a symptomatic relief?
No, that's a really good explanation, actually, because I think it's quite complicated, that one. But one thing that's not as complicated but becoming more popular is kind of, I guess, more sort of left field treatments, like almost like natural flora modulation. So people are asking about probiotics and even sort of fecal transplants.
Yes.
Is that a thing? And is there some?
Yeah, I mean, I think again, this is an evolving area. So there was a time when we used to think that the bladder was basically sterile, as in there were just no bacteria and there were very little bacteria. We now know that that's not true. Actually, there is the bladder itself, although it has very low levels, it does have natural bacteria that are there. And just like you do in so many other parts of the body, and those bacteria, we call the microbiome, have play a role in maintaining the bladder in a healthy state. And therefore, this is the idea of particular probiotics, is that trying to encourage the good bacteria. And particularly in women, we also know that there are good bacteria within the vagina that can stop bad bacteria taking hold there. So when we were talking earlier about the fact that bacteria ascend up through the water pipe, and often they can colonize the vagina. So using probiotics can help enhance the flora, the normal natural bacteria that are within the vagina, and help and help hopefully reduce urinary tract infections, and particularly recurring urinary tract infections. So there has been, there is some suggestion that can be beneficial. Again, I think the evidence is still evolving. People are doing studies. It's not an easy thing to work out, really, because everybody's microbiome is a little bit different. Getting bacteria, I mean, it's not just a case, you have a tablet and the bacteria magically find their way to the right place. I mean, there's a lot of work to be done on how do you get the bacteria in the right place, get them to survive, because remember, our gut is really good at getting rid of stuff. As soon as you eat anything goes into your tummy, it's full of acid and destroys a whole bunch of stuff. So, getting the right bacteria to the right place, is it via, is the best way via tablets? Is it via some kind of, agent put in vaginally, like, I don't know, cream or something like that? So there's all sorts of, lots of questions about this and how this would work. Obviously, one very direct way of changing the bacteria is, as what you were alluding to before, is fecal transplant. I think this is obviously pretty extreme. But there are situations, and I think I've seen it done it's been done in transplant, where you've got patients who've got transplant. So this is really high stakes here, because if you're getting problems with recurring urinary infection, and you've got a transplanted kidney, it could just ruin that kidney over time. And they've detected those bacteria are actually essentially living within that person's bowel. They're there, and so they've gone and done a fecal transplant, and actually managed to change the situation and reduce the usage. So I think this is pretty extreme, at least at the moment. However, from a kind of almost like a proof of principle, i.e., can changing the bacteria have an impact on what's going on? It shows that yes, that is something that could be done. So I think this is definitely a space to watch. I know there's a lot across medicine generally, in almost every area. People are looking more and more at the microbiome, this idea of what are the different bacteria that we carry, and what are the benefits and drawbacks. So I think we're going to learn more about that. In the meantime, I think it's not unreasonable to try probiotics in these situations. I know a number of patients have had positive benefits from it.
Any kind of probiotic, I'm guessing, that you can buy in a supplement form.
Yeah, I mean, there are certain manufacturers that are producing specifically for helping with urinary tract infections. So I guess that's a reasonable place to start. In honesty, I personally, I'm not saying it doesn't, but I personally haven't seen any great evidence to say that, okay, this is the one that you should definitely use, and this is the one that I hope that comes through. And I definitely have seen studies where people are showing different positive effects, but there's not like a clear front runner at the moment. I could say that, that's the one.